Dr. Sabrina Siegel with the Neuroscience Education Institute, and twice a month, I sit down with a renowned mental health care expert to discuss breakthroughs and best practices for treating patients with mental illness.
Good afternoon, or it's almost good evening. I'm Will Sauve, as I think some of you know, and this presentation is entitled Situation Critical, the Impact of COVID-19 on Mental Health Care, a subject, by this time I think we all know pretty well. I'm the Regional Medical Director of Greenbrook TMS NeuroHealth Centers in Virginia. Same thing it's been for the past several years. I'll take a quick second to go through disclosure. Once again, so far, only one, Speakers Bureau Avenir, and I don't really do any other outside activities. So as it's been for the past several years, I'm kind of all transcranial magnetic stimulation all the time. And then here with NEI is my favorite place to be. Whatever you do, don't forget to answer the pre-test questions. So there'll be a few minutes to click on the polls on the panel on the right side of your screen. And once you've done that, we'll get moving with today's topic. So learning objectives for today, number one, explore the potential impact of COVID-19 on a variety of psychiatric issues. Number two, discuss the implications of COVID-19 induced or exacerbated mental health issues on the care of patients. So in the year 2019 to 2020, we got coronavirus, right? Coronavirus disease 2019, otherwise known, colloquially as COVID-19, resulting in an unprecedented global pandemic. Physically, the underlying virus, a beta coronavirus, can cause severe respiratory distress and lead to death, and we've seen that. However, the impact of COVID-19 pandemic may go well beyond the physical complications. Emerging data, historical studies, and expert opinion point to a tremendous impact of COVID-19 on the development and exacerbation of psychiatric issues. The pandemic has served to amplify personal, social, and economic costs of mental illness to a magnitude that's unprecedented. And that would definitely be my take on this issue. I'm not 100% convinced, and this can be addressed in the question and answers later, that outside stressors can necessarily cause psychiatric issues and illnesses per se. However, I've had the opportunity to talk about this, at home and at the practice for the past several months. I am fully convinced that there is a large slice of the population who have not been well, but been well enough that they can either sort of exist in denial, or they know they don't feel well, but they don't really have the time, to address their illness because they're going to work every day. They're making the lunches every day. These are people who are getting by. These are the kind of people that come to me for TMS, that I tend to call them the walking wounded. And something like COVID-19 that makes such a big change in all of our lives can basically, I would say, and I don't think this is particularly controversial, cause this massive slice of the population to decompensate. So as one of my instructors used to say to me, that the car, right, is going around the beltway at 65 miles an hour, and to everybody looking, it looks like all four wheels fell off all at once. Right? We know that car was not 100% fine, and then suddenly all four wheels just flew off the car. It's like that car's been braking for a long time, but it looked okay on the outside until something, say for instance, a brand new virus called COVID-19 came along, did that last little turn of the screw, and everything kind of fell apart. I would say that is basically what we're living with now. The global lockdown and the response to the pandemic resulted in physical distancing, social isolation, loss of jobs, loss of income. I mean, that's all we see in the news now. Loneliness, lack of activity. For years, and this is probably no surprise to anybody watching, I have been listening to people tell me, how much they dislike being around other people and how much they would love it if they could just be by themselves all the time. I think a lot of people found out the hard way over the last year that that's actually not true for them at all. Right? And many, many, many people hadn't really thought about what they would do if suddenly they were either stuck at home out of work or even working at home, not something that they've done before, and didn't really have a structure built in. And I had people telling me that they hadn't showered in a week because it never occurred to them how this might go if you had to live through this, inactivity, not being around people, increased access to food, alcohol, online gambling. That's with nothing to do but stare at the computer, and eventually you can fall into online gambling, and then not really having family and social supports available. The downturn in the economy, of course, resulted in massive unemployment, financial insecurity across the board, and then poverty, which then makes it very difficult for people to get the health care that they're accustomed to, people losing their insurance, and ultimately, this can lead to massive gaps in mental health care. So if you look at just what the CDC has to say, right, the statistics are sobering. In January, June of 2019, we see kind of a steady symptoms of anxiety, 8.2%, depression, 6.6%, symptoms of, anxiety disorders, 11.0%. And then suddenly, April 23rd to May 5th, 30.8%, 23.5%, 35.9%. And then, it just kind of gets worse from there. If you look at July 9th through July 14th, 2020, again, I don't really think that people who were completely well, suddenly got anxiety disorders, got depressive disorders, got anxiety or depressive disorders together. I strongly suspect that these were people who were not perfectly well, but were getting by, as they might say, kind of compensated. And then in the face of all this, suddenly, the veil of denial is ripped off, and they start answering these questions. Yes, I do feel depressed and anxious, because there's nothing really to distract from those feelings anymore. So in published study and survey results, the direct impact of quarantine, right, and in a lot of ways, it's not really quarantine. We don't have another word for it. Quarantine is what happens when you're sick, and then you go into quarantine so other people, don't have to come near you. This is sort of a reverse quarantine where everybody had to stay home, so people are locked up at home. So call it lockdown. I think the WHO referred to it that way recently. Quarantine, whatever you like, but basically distancing and isolation, which resulted in increased psychosocial stressors and fear of illness. And I think we've all seen that in the clinic. For the month of March, I didn't see anybody in the clinic because people were literally afraid to leave their houses. They didn't know what was going to happen. So even though we stayed open, we didn't think that we could stop treating patients. I didn't really think that the kind of depression that we treat, would be what you would call an elective procedure. However, if people were afraid to come into the office, then they still aren't going to come in for treatment, no matter how open our doors were. People are also afraid of, negative economic impact, and that's not an unfair thing to be afraid of. People are also reporting phobic anxiety, panic buying. Can we get toilet paper yet? It's still hard to find the little disinfectant wipes, right? It's been months and months and months and months, and still they get cleaned out of the shelves, and still, there are signs up all over the drugstore that says 1 per customer, because whenever they become available, they get cleaned out. I have to believe that there's a salt mine somewhere in this country that has about a gazillion, pieces of toilet paper and the wipies where somebody is stashing them all, because I can't believe this many have disappeared. Social media exposure, again, I don't know if it's any big surprise that, social media is turning into a thing that, people are finding that anxiety inducing, spending too much time with it. So then suddenly, the things that would normally keep you away from social media, say, for instance, work, is gone. And we have large numbers of people that are glued to that Facebook screen all day, and then reporting significant anxiety, stress, anger, increase in risky behaviors like the online gambling. A lot of young people starting to make calls to helplines complaining of anxiety. And there was an increase in alcohol sales and alcohol use in the home, which could potentially have increased alcohol use disorder and potentially contributed to domestic violence. And there were increased calls to domestic abuse and child abuse hotlines. So most importantly, those with pre-existing mental health disorders, and again, my thoughts are that probably the majority of these manifestations of mental health were pre-existing. It's more of a question of which ones were known to be pre-existing and which ones weren't. But that said, people with pre-existing mental health disorders might have a higher risk of the COVID infection than those without mental health disorders. Also, risk factors for infection with SARS-CoV-2 or COVID-19 and a severe course would include mental illness, alcohol or drug misuse, and homelessness, all of which are associated with other risk factors such as comorbid physical conditions. And I would simply add to that, anybody who is treating a population that suffers from somewhere between, I would say, significant to severe mental illness, moderate to severe depression, psychotic disorders, anxiety disorders. I don't have the ability right now to do what I like to do and ask for a show of hands, but in a pretend show of hands, how many of you would say that the vast majority of these patients have metabolic syndrome to some degree? And then, go back to a recent study now from the last year that suggested 88% of Americans overall suffer from metabolic syndrome to some degree, either mild and then all the way up to and including, type 2 diabetes and cardiovascular complications. So the metabolic syndrome, the insulin resistance, type 2 diabetes, and cardiovascular problems aren't unique to the population that suffers from mental health problems, but I would certainly say that it's overrepresented in the population that suffers from mental health problems. People with mental disorders are also at increased risk of infections in general, statistically, therefore potentially at increased risk of COVID-19. And then they're more likely to develop severe organ dysfunction and to die in the ICU than people without mental health disorders. So for those with pre-existing mental health disorders, again, when you look at the surveys, quarantine, lockdown has resulted in increased symptoms and poorer access to services and supports since the onset of the pandemic. Also, early discharge from psychiatric units. And these were the things that, well, I suppose they kind of hit us all in the gut, as the thought that we've been concerned about people being discharged from inpatient psychiatric hospitals, too soon anyway. And then suddenly, starting in March, we're seeing people get discharged from the unit based on the logic that it might not be safe for them to be in the inpatient unit because of COVID, but now they might be, severely ill and out in the street. And the negative consequences can include relapse, suicidal behavior, lack of medical care, social isolation, which then can lead to all sorts of problems in that vulnerable population. Increased symptoms of anxiety and depression, high rates of PTSD have been reported. So physical distancing has reduced the availability of many family social psychiatric supports. AA, right? That went away in the blink of an eye. And that, I don't care who you ask, doing AA on Zoom is just not the same thing. So I heard that, time and time and time again, starting in March, that many people were very concerned about their ability to maintain their sobriety because suddenly, these typical things weren't available to them. People with serious mental health problems and associated socioeconomic disadvantages are particularly vulnerable in these cases. Increased symptoms of vulnerability have been reported during COVID-19 in people with eating disorders, autistic spectrum disorder, dementia, and think about, with all the nursing homes being locked down and the horrible stories. I don't know that there was any way to avoid it, but the horrible stories that we read about people that were perhaps in the early or late stages of dementia and their families couldn't visit them and they're trapped, in a nursing home and isolated and can't see anybody. And then intellectual and developmental disabilities are also vulnerable. Confinement at home, disruption of the daily routine, all of these things can basically exacerbate conditions across the board and make it hard for people to give the care that they would normally give. As far as healthcare and mental health care disparities, higher mortality from COVID-19 has been documented in the African American populations in New Orleans, Chicago, Milwaukee, Michigan, Georgia. 70% of death cases from COVID-19 in Louisiana are African American, where they only make up a much smaller percent of the population. Similarly, African Americans comprise 14% of the population of Michigan, but represent 40% of the COVID deaths. And the top three underlying conditions among COVID-19 Louisiana deaths are hypertension, diabetes, and chronic kidney disease. Hypertension is the most prominent risk factor in African Americans. It's been that way for time immemorial. Now, that it's not necessarily a causal relationship, but it was a pretty strong correlation across the board. Hypertension, type 2 diabetes, right, has always been a thing in that population. And then COVID comes along. And again, you're particularly vulnerable with metabolic syndrome, metabolic perturbations. And then suddenly we're looking at a massive, disproportionate ICU admission and death rate. It's probably not just simple lifestyle choices. And, sometimes when allowed to, I can get to be a little bit of an evangelist about nutrition. And so that is kind of right up my alley, but it's definitely not simply because people are choosing, right, to eat the wrong things and now they have metabolic problems. There's all sorts of issues like availability of certain kinds of food, depending on where you live, how expensive it is or isn't, how easy it is to find, level of education. Quite a few people, they would have no way of knowing that, certain things might be exacerbating the cardiovascular disease, the hypertension, the metabolic syndrome. And then suddenly here we are with COVID-19 just ripping through potentially this metabolically ill population. So what could possibly be done now, to address these healthcare disparities? And this was looked at in the Journal of the American College of Cardiology. A few things to think about. Number one, targeted, culturally sensitive, literacy level, appropriate mitigation, education. That's a mouthful. So social distancing, masks, hand washing. In other words, trying to reach out to certain populations as simple, potentially inexpensive things they can do to simply try to mitigate risk. Mandated personal protection for essential service workers. I think for the most part, a lot of that's already been done, and it can probably be done more. Financial protection, insurance for non-covered workers, all that's being argued about now, right? So we're hearing about that. Targeted testing in crowded housing environments. So that's a real thing. I mean, think in some cities where people are kind of jammed together in housing, and in some cities where people are homeless and they're all on top of each other. Not before COVID-19 hit, you could find plenty of references to typhus ripping through, homeless camps in certain cities. And there was actually even some concern that there might be an outbreak of plague, at some point when the rat population was starting to get to a certain level compared with the homeless population in certain cities. So something like COVID that, appears to be spreading through droplets, that would be no exception if people are close together, probably not wearing masks, in that particular environment, or necessarily being particularly concerned about staying at least 6 feet apart, which when it comes to droplets, probably more like 20 feet apart. So those are things to definitely think about. Testing beyond symptomatic individuals, again, that's still being worked upon. Some sort of ability to test people quickly and be able to get people very early on in the course of the illness. If you could have rapid and inexpensive testing the essential workers, so that maybe you could start deciding who can go to work and who needs to stay home instead of just a broad lockdown. Also, maybe making telemedicine a little bit better. I would suggest that everything we've gone through with COVID has gone a really long way to kind of reveal some of the holes, in the wicker basket that we call our system. So telemedicine is great. It certainly has a lot of flaws. And I think on a daily basis, we're finding out the hard way, how maybe it doesn't necessarily serve certain people, whether that means, maybe someone doesn't have a really good way of monitoring their blood pressure. So when you're looking at them on a Zoom screen, you can't exactly see what their blood pressure is. So what exactly are you going to do? And then other issues like that. They do recommend in the College of Cardiology encourage heart-healthy eating, and that's great, but I don't know how many people know exactly what that is. So that's kind of a big goal there. Low cost or free virtual activities online. I think people across the country are trying to do that. Some are being more successful than others. Thermometers and pulse oximeters to monitor COVID-19 status in affected patients. Great idea. This equipment is not particularly expensive, and possibly just like the disinfecting wipes. It might just be that they're a little hard to get right now, but probably not a bad idea at all. And then, continuing to work on the project to figure out when there are significant disparities in the way people are being affected by this, like how that might actually be addressed. As far as mental health care workers on the front line, what this refers to has to do with the trauma experienced by healthcare workers, people that were suddenly thrust into this situation. So think about, this quote, I have 18 beds in one ICU full of people on ventilators, completely sedated, unable to open their eyes or interact or talk with their families. And goes on to describe that everything is full. The ICU seems to have every bed filled within a couple hours. And in the first week or two of the whole pandemic, when it kind of blew up, people in this situation didn't really know how bad it was going to be. I thought about this for quite some time because I think I have a biased perspective of having been a military physician. So when I went to the Uniformed Services School, this was one of my mandatory classes. Right? We were trained on a very regular basis, all the way from the classroom up to and including, doing exercises where, people had to act like wounded, doing full-on moulage, all about the mass casualty situation. So, like, on the one hand, I read something like this and I think this is exactly what I did in school, and then experience somewhat similar situations, once or twice in my career. I'm either deployed or in a variety of hospital situations. But on the other hand, I can completely see what they're describing, that in the moment, every bed is full. You're surrounded by people that you may or may not be able to help. I'm not sure that everyone in that situation was really taught, how to support or how to even sort out when it comes to triage, who exactly you can help or who you can't. And in the United States, I think we've all kind of grown up to take for granted that we can help everybody because we've been able to, for most of our lives. And all of a sudden, that all kind of comes crashing down. So it brings up an interesting conversation of moral injury in physicians and healthcare workers, which I do think is very interesting. More about that later. Healthcare workers, especially on the front line during COVID-19, reported negative consequences, including stress exposure, right, fear of infecting themselves, fear of infecting loved ones. Again, this is what I was trained for in medical school, that we have a mass casualty situation and the bullets are flying very close to where we're standing. So either a fear of being infected or a fear of being shot. I thought, I get that. Like that, yeah, that can be a rough way to have to do medicine, particularly if you weren't specifically trained for it in school. And I fear that more people than not, working in our kind of first world, top tier medical system really didn't sign up for that. Nobody said when you come to work at a wonderful hospital in New York City that you might end up in the middle of a mass casualty situation in downtown Manhattan. In a cross-sectional study of 1,257 people in 34 hospitals in China, they got 50% reported symptoms of depression, 45% reported anxiety, 34% reported insomnia, 72% reported distress. And where I come from, we probably would have called that battle fatigue, before it actually grew into what we would eventually call PTSD. And common risk factors, including a lack of social support and communication, which that's exacerbated because of social distancing, right? And we saw those pictures and really sad stories, actually, of people who worked in the hospitals that then they didn't feel that it was safe for them to come home and be with their families at night. I read a story of one doctor that pitched a tent in his yard and he was sleeping outside in the yard every night because he was very afraid to be in contact with his family because he didn't know that he maybe had picked up the virus and he was afraid to give it to them. So after a whole day of going through this experience, then he goes home, waves to his family through the window and sleeps in a tent outside in the cold. And then again, moral injury, which is a very interesting thing. Moral injury, it's been a little bit of a controversial point back when I was on active duty. Number one, the first time I ever heard of Dr. John Shea, the guy who wrote Achilles in Vietnam, which is worth reading if you're interested in learning about that kind of post-combat experience. He mentioned moral injury in front of a bunch of Marines, and I thought one of them was going to shoot him, because there was this suggestion somehow that you feel guilty about what you did, and a bunch of combat veterans were ready to say, like, not only do I not feel guilty, but I'm going to show you with my fists just how not guilty I feel. And then a psychiatrist would say, your anger means I'm right, as you're being beat to the ground by a bunch of angry Marines. But that isn't what they thought it meant, isn't really what it meant. So there's a lot of bullets here comparing a military example of what moral injury can be versus like what a healthcare example of moral injury could be. I would sum that up as being all kind of one thing, which is in a life or death situation, you are forced to behave in a certain way. And even though any rational person would say that you did right and you made the best choice you possibly could, in your soul, it still feels like it was a bad thing to do. And that creates an internal conflict, and all psychic pain kind of comes from the internal conflict, ergo the moral injury. What that all boils down in combat, I mean, certainly, it's fair to talk about like whether or not somebody witnessed atrocities, Geneva Conventions, and maybe a bad commander that went against it and you didn't feel like you could say anything. But at the end of the day, probably the most common example in combat is having to kill someone in order to save your own life. Nobody would ever say that you were a bad person for using your weapon to do what you were supposed to do in combat, and you won the fight and the other guy didn't. However, most humans will still walk away from that feeling like they murdered another human being. And it is very, very difficult to reconcile that in your mind. Moral injury. In the civilian healthcare environment, probably the best example on this list is the one where you have to choose between two equally sick patients. Hypothetical cartoon situation, right? You have one injection that will save the life, and you have two people who both equally need it. And no matter what you do, you have to pick one, no matter what you do, right? No rational person, if you give each of them half of an injection, they both die. If you don't give either of them the injection, they both die. So the best decision you could have made was giving it to one. Most humans will walk away from that still feeling like they killed the other person. And that's a very, very difficult thing to get over by yourself. And then in some cases, it led to the worst outcome possible. And I would never say that, somebody committed suicide because one thing. It's highly possible that in any cases like this, it was something coming for a long time, but it's also highly possible that, if someone was kind of getting by, and then an unexpected situation like this that could have included all of those symptoms of, again, what we kind of used to call battle fatigue and also moral injury. And then if it goes on long enough, you might even call it PTSD. Some people might decompensate and decide that that's it and they can't do it anymore. And that's the thing that made them take an action like this. So with COVID-19 and suicide, there was a regression analysis done. And actually, this is brought to you by my good friend, Dr. McIntyre. So say hi to him when you see him for me. But this gave us kind of a sobering statistic that basically, best case scenario, you see suicides go up a little bit, right, with a change in unemployment rates. So it seems like suicide rates follow unemployment rates pretty tightly. And in a best case scenario, unemployment rates, they go up a little bit and suicide goes up a little bit. But then when you see is that third big red line is this massive, 16.6% increase in suicide if unemployment goes as bad as we think it might be in the context of the economic consequences of COVID-19. So what if my patient has or had COVID-19? So making it a little bit personal, and instead of looking at, the whole big like nationwide level. Number one, for people with COVID-19, lack of contact with family or loved ones during, any kind of quarantine or hospital stays can produce psychological instability. I'm not sure that, there's a lot of individuals walking around, again, they're not 100% conscious of how much they are actually relying on people around them for social support and to help them stay well. And then, suddenly all alone, no one really to talk to. Online isn't really the same, and not everybody really has complete access to that or necessarily even knows how to use it anyway. And what might have been a fairly tenuous level of stability can start to fall apart. High rates of post-traumatic symptoms have been reported in clinically stable patients discharged from the hospital after recovering. So somebody who got COVID-19 and I would say quite literally had the fear put into them, especially imagine you got COVID-19 and you were hospitalized in April. And in April, no matter what, there's a high likelihood that you were led to believe that your chances of dying were pretty high. And everyone around you is feeling pretty helpless, and you're feeling pretty helpless. And that is a setup, for having kind of post-traumatic type stuff, whether it's acute stress disorder or eventually turns into PTSD. Also, people who had COVID-19 can experience post-intensive care syndrome, or just a consequence of having been in the ICU. And in previous research, people who recovered from other severe coronaviruses, so think like the original SARS and MERS, 32.2 had PTSD, 14.9% had depression, 14.8% experienced anxiety. So you could kind of expect that this might go the same way. So up to a third of the American population that over the past several months, and then maybe even some more in the coming months, who had a severe bout with COVID-19, up to a third of them could end up presenting with PTSD down the road. And they're going to be coming to us for that. Studies on people who recovered, and this has to do with the post-ICU syndrome. You get delirium, agitation, altered consciousness, and so on and so on and so on. So that's also a concern to watch for in the acute phase, nothing to do with the PTSD. So meeting patients' mental health needs in the midst of COVID-19. See if there's anything that we can do that can make a dent in all this. Couple things to think about. Number one, when it comes to patients on antipsychotic medications, and particularly the long-acting injectables, right? Probably part of me kind of thinks that if I have a population of people on long-acting injectables, I would like to have a spreadsheet of all of them anyway right now, like before COVID-19, because that is probably a group that I would like to kind of track fairly carefully. But certainly under current circumstances, yes, that's a good idea in keeping track of everybody, because it is pretty easy, for people to sort of fall off the table. And next thing you know, it's like, it's been how long since you had your injection? And you're kind of starting from scratch. For patients who usually travel to a clinic, it might be useful to see if there's something that can be found for them that's more local. I mean, easier said than done for anyone who has worked at trying to set up getting long-acting injectables and for someone to be able to get those injections on a regular basis. But this would be a great time to see if there's a more local resource for them and kind of minimize that travel and foot traffic. Sometimes it can be done at pharmacies. That might be helpful. There might be visiting nurses, though in some situations the visiting nurses coming to people's homes stopped, at least temporarily. So that might have been disrupted as well. Probably not ideal. It says it may not be ideal to make medication changes. I'm going to say probably not ideal to make any changes if they can be avoided, since we're already sort of living with the one giant change. I don't know that I want to add logs onto that fire. However, some changes within medications might be the way to go if it can make people's follow-up times a little bit longer. If there was a way to kind of facilitate people being able to hang on a little bit longer when it's harder for them to get in. And good example, like Risperdal Consta, that's every 2 weeks. Maybe it will be a little better right now if they could have like a once a month Invega Sustenna or a once every 3 months like Trinza, if that was going to work for them. And then, all of these long-acting injectables, they have some instructions for what to do if people miss a shot. So it's important to pay attention to that. Some people might actually need, the dose bumped up, like maybe to try to be a buffer against missing a shot, but maybe because, stress level is up like a good 10, 15, 20%. And maybe right now a higher dose might help somebody avoid decompensating. During a public health emergency, some family members might be able to be trained to give an injection. That's probably going to be a pretty special thing. So like maybe, if that's all there is. And then it might be necessary or might be possible to just go back to oral medications, at least temporarily. Also thinking about like people on medications who get COVID-19 and how their symptoms and the medications being used to treat them might actually be affected by the whole COVID-19 thing. Number one, your COVID-19 is causing like hematologic and coagulation problems. So medications that potentially interfere with that are worth paying attention to. I'd say the big one is the psychotropics that prolong the QT interval. I mean, in the field of mental health, I think we deal with that quite a bit anyway. And that when I spent the last time I was working in an inpatient setting on a fairly regular basis, we'd have someone on quetiapine and on citalopram. They would have come in through the emergency room. The emergency room invariably diagnosed them with a urinary tract infection and started them on Cipro. And at that point, the pharmacist would walk up and punch me in the face and demand that we get an EEG and stop something. And usually we could stop the Cipro and therefore not have 3 drugs all at the same time that are potentially affecting the QT interval. So with our population, again, they're kind of at high risk to be on these atypical antipsychotics, citalopram, TCAs, all kind of stacking up so that the QT interval is maybe getting a little close to where you don't want it to be anyway, and then adding certain drugs such as hydroxychloroquine might be, for someone who wasn't on all those drugs, it might not have been a thing, but for one of our patients, it might have. Plenty of hepatic risks coming with COVID-19, and quite a few of the medications that we use already present that. So it might not be possible to avoid those psychotropics, but again, it's worth thinking about. And try not to start any of them new if that patient is already at risk. Renal issues can also be a problem. The entire nervous system, and not just thinking about like drugs that affect the nervous system, but drugs that can depress the nervous system and drugs that might depress the respiratory system when you're looking at pulmonary. And then things that might lower the seizure threshold could also be an issue with COVID-19 because that's a risk too. As far as interactions, some of the drugs that are being used right now to treat COVID-19, you got azithromycin, chloroquine, hydroxychloroquine, colchicine, right? That was a thing back in June that it might have had like some anti-inflammatory benefit. I haven't heard much about it since then, but it's still on the list. Corticosteroids, and corticosteroids, I'll zero in on that for a second. I treated someone in the hospital, and I'm sure more than one person has, but I have actually seen personally someone who did not have bipolar disorder, who got started on a course of corticosteroids for a perfectly reasonable reason, and within 48 hours was in the hospital completely manic and psychotic. Right? And I took care of her, and it was an active duty situation, so it was actually a whole rigmarole kind of proving that, no, I did not believe she had bipolar disorder, that this was completely drug-induced. So it may be possible that someone who actually has not been identified as having any mental health problems at all could potentially become hypomanic or manic in the hospital while being treated with corticosteroids for COVID-19. And if they're already at risk, and then corticosteroids on top of that, and that would be an important thing for the consulting psychiatrist on the floor to know about. Interferon, favipiravir, possible QTC prolongation. Also with interferon, kind of famous over the years that sometimes interferon actually seems to cause depression. That's important to watch out for that. And then you have the cytochrome P450 system to think about with some of these drugs. And then vitamin C. Co-administration with barbiturates may decrease the effects of vitamin C. So if we have, any one of our patients who for one reason or another is being treated with barbiturates, then it might be important to know that, because the vitamin C might not actually work the same way if that's being used as kind of part of their COVID-19 treatment milieu. As far as changes to mental health care with telepsychiatry, well, the research has all kind of indicated that telepsychiatry can be pretty good. Right? Previous research indicates that telepsychiatry is comparable to face-to-face services with the reliability of the treatment outcome. So I guess if you're looking at outcomes, you get good results and it can go just as well. It's also been shown to deliver some high patient satisfaction. Caveat, I'll bring it up again. I don't think that any of my patients would give lower satisfaction scores, but it's still very striking to me that at least half of them just can't wait to get off the line. So sometimes I end up having like a string of like very abbreviated patient interactions during the day when I'm doing telepsych, because people have the time, they know they have the time, and they just want to be done and they want to be off that thing. So that's very interesting, and I don't really know what that's going to like result in terms of rapport down the road. During COVID-19, telepsych has allowed for the preservation of a large proportion of patient interactions. And that's a good thing. And that, we did that again with TMS. Most of what I do has to be done in person. It's a procedure. So they can't not come to the office. But in March, when people weren't coming to the office because they were afraid to leave their house, we implemented telepsychiatry if for no other reason than to keep people engaged. I could still do follow-ups. I could still do initial assessments of people who were thinking about TMS, and maybe even give people the opportunity to like have a full assessment with me, decide that they wanted the treatment, then they might be able to overcome the anxiety and with the proper precautions come into the office. So I personally would agree that yes, it did go a long way towards preserving quite a bit of that patient contract and keeping a lot of people in care that might have fallen away otherwise. Patients with severe anxiety disorders, yes, some of them love it. That kind of a fun thing to say. Sometimes I'm not sure if facilitating someone's ability to stay home because of an anxiety disorder is necessarily therapeutic. But then again, if they never would have come to see you because of an anxiety disorder, and now they will make that initial contact because they can do it online, that might be the foot in the door towards an eventual therapeutic experience. So I can kind of see it going both ways. Caution must be taken with respect to socioeconomic status and computer literacy and age profiles. And interestingly, I'm actually finding it isn't just older people that are having a hard time with the computers. And I'm still trying to figure that out. So earnestly, I'm 46 years old. Right? I am firmly in Gen X. Had my first computer when I was 10, built my first computer when I was a teenager, and then programmed databases, programmed HTML. I realized that my parents didn't know anything about computers because they thought computers were stupid, because they were old enough that my dad's like, why can't I just do this with a pencil and paper? And to this day, we still kind of have that argument. So it didn't surprise me that people, 10 years older than myself and older than that are potentially computer illiterate, have a hard time using things like Zoom, maybe don't see the point, they're very unmotivated to do it. But I'm also finding that people who are 20 years my junior also don't seem to know how to use a great deal of the technology. And this might also be interesting if anybody wants to kind of jump in on the Q&A, but I'm wondering if it's possible that for people of a certain age, the only computer they've really ever known is an iPhone, which means it always did what it's supposed to do, like magic, and they actually have no idea how it does that. So if it ever does anything they don't expect, they just decompensate. And that's kind of what I'm seeing on Zoom. I wonder if other people see that also on like not just Zoom, but any other telepsych platform, that if people press the button and it shows them the picture and gives them the sound, we're good to go. And if it does anything but that, it becomes like a full 15 minutes of nobody knows what to do, and we go in circles and half the time end up giving up because most people don't really seem to have a handle on dealing with the technology. And I'm not even convinced it's completely because of like socioeconomic status. It seems to be a lot of people across the board. Additional research is also needed to determine kind of the optimal methods of video teleconference group delivery to maximize clinical benefit and treatment outcomes. And yeah, I'm interested in that too. I don't really know if you can do group delivery with video teleconference effectively in a therapeutic environment, but I'm eager to see, just how possible that might be. So considerations in telepsych even in addition, to the interesting little conundrum that I just pointed out, you might also have people who have, like, think MCI, right? Mild cognitive impairment, that anything about, working with a computer and relatively complicated technology might be difficult. Visually impaired, hearing impaired, a lot of the teleconferencing is going to be very difficult. Less technologically literate, and I'm thinking that is non-discriminatory, that people old and young quite commonly seem to have, almost no ability to deal with a computer, especially if it's acting up. And poor dexterity, like, in other words, maybe just difficulty with the keys, finding that to be a bit much. Low income, that might also mean specifically the lack of required technology, that people don't have an appropriate, they might have a phone that works. They might even have a phone that you would call a smartphone. But if that phone is more than a few generations old, using it for some kind of video conferencing might not go well at all. I also find that a lot of people, speaking of geographic location, they are literally sneaking out of work for their appointment because somehow having a teleconference appointment means an excuse to not actually take the time away. So they leave work and they go in their car, because that's maybe the only private place, and their car is in the parking lot where they have no signal. And then we end up spending, the entire appointment kind of jumping on and off with the video coming and going, and having all those problems because they're trying to do a doctor's appointment in their car that's like halfway in the woods because they were trying to get away from other people. As far as pointers, make sure the consent is obtained prior to beginning telepsychiatry sessions, and make sure the patient understands it won't be in person. It seems obvious, but I've heard that before. More than one person I've heard complaining, actually someone in front of me at line at the store for no reason was very loudly telling the cashier about 3 feet in front of me that she was pretty unhappy because she had an appointment to see the doctor, and about 30 minutes prior she was informed that no, she was not going to be seen at the doctor's office. It was all going to be online. And then she didn't particularly mind that, but it was just the sudden change, and she was probably already dressed. So that does happen. Needs to be a HIPAA-approved platform. I think we've all known that for some time. Strive to protect privacy. I would argue, you can tell the patient that they ought to protect their privacy, but a lot of people are in their own home and they don't necessarily care to do that. And many, many times I've seen family members walking behind, and I think if someone's been told that they perhaps can and should protect their privacy, then it's their privacy to protect. So they're going to do that. It's important for your technology to work, right? So it needs to be, a half decent microphone so people can hear you, half decent, lighting, and nothing too, silly or unprofessional in the background. So it still sort of looks like the doctor's office environment. Establishing and maintaining virtual eye contact. So, long, hard stare right into the camera, right? That shows aggression. So you want to do that as hard as you can. Try not to show too much aggression, but do try to not get sucked into a situation where you're looking down, or sometimes the camera is actually to the side of the computer and the whole visit is done like this. Maybe with people not realizing that they weren't actually looking anywhere near the camera when they were talking to the patient. Interestingly, I've read about technology where the camera, the computer, is actually going to find your eyes and make you into like a virtual Mona Lisa. So there may actually come a day when the eye contact won't be a thing anymore, because the computer will just find your eyes and it will just somehow edit the picture on the fly so that to anybody looking at the screen, you always look like you're looking right at them, which is creepy. Potential negative effects. Focus of the healthcare system on identification, prevention, and management of COVID-19 meant that everything kind of went physical health. And then all anybody could talk about, right, is social distancing instead of like physical distancing while trying to stay connected to each other. So maybe we kind of overemphasized that, and everybody got, just a little bit too far apart. Most of resources kind of all went to, it's like, well, we got to treat, everything COVID. It isn't just mental health that lost out, right? We're already seeing reports of people who were not getting screened for cancer, hearing stories about, people who didn't go to the hospital when they had chest pain and they died. So there were plenty of areas of medicine that just got completely backburnered because we were so scared, not necessarily wrongly so, of COVID. And for, I think, a long time to come, we're going to be looking at the consequences of having ignored a lot of stuff for a long time. But mental health was certainly a big part of that. And a lot of, fewer in-person meetings within and across treatment teams, right? Many mental health practices across the country went, completely online. It's nice to be able to do that stuff online, but then again, you, the practitioner, you're trapped at home all day too. How many professional interactions with colleagues are you not getting because you're at home just doing tele all day? And how isolating is that for you? And then we've always had shortages of healthcare workers across the board, for many years now. And I think that just got even more exacerbated. We restricted access to other kinds of healthcare. Everything got, urgent only. Had you been, talking to me or hearing from me in, March, April, and May, I was arguing that many things that were being called elective, in my opinion, are not elective. So that's I'm still mad about that. And I think a lot of people probably are. But, the truth is a lot of stuff got locked down. And again, a lot of medical care that I don't think is elective at all kind of got completely brushed to the side because of this idea that we could only do emergent things. Group psychotherapy, a lot of that went away. Again, AA, almost completely gone across the board. And some people were able to kind of do it in a teleconference way, but that's about it. When it comes to, quite a few of our patients that they need their, cardiometabolic labs drawn every few months, maybe that's not getting done. Total inpatient beds. There's an article in the Wall Street Journal just last week that multiple hospitals across the country have just completely killed mental health because, it wasn't really economically great for them before. And then under COVID-19, it got worse. And they started cutting things, to try to stop the money going out the door. And mental health was kind of first on the list. So again, people would have told you we didn't have enough inpatient beds kind of across the nation before. And there's even fewer now. Constraints on hospital admission and people getting booted out of the hospital early, maybe again for very valid fears of COVID, but it doesn't change the fact that, somebody is being discharged when they're still pretty unstable and still pretty ill. As far as potential positive effects, it's okay. Lancet Psychiatry looking at this, I feel like we're polishing, the thing that you polish when you're trying to make something bad look good. But all right, there could be an education about mental health effects of COVID-19, increasing overall mental health literacy. I would definitely call that learning the hard way, but yes, there might be some increase there. There might be more opportunity to kind of help people talk about taking care of themselves because it's more necessary now because we've learned that, a lot of that stuff falls apart when we're under stress. There could be programs that come to bear and, we'll see as the future comes around, whether or not they're useful. The technology could get a lot better. I'm actually really excited about that. I mean, again, one example, telehealth at our practice where I am, we talked about it for years and it didn't really do it, I would say, truly because of inertia. Corporate inertia, the procedure that I do all day is in person. So, we'd always kind of talk about how telehealth fits in. Well, COVID meant we had to do it and we did it in about 10 seconds. We implemented it so fast. I didn't know we could do that fast. And I could see how many other entities across the country might start making things happen very, very quickly now that the motivation to do that is so high. Promotion of healthy physical and mental lifestyle measures. Yeah, we'll see. It's I'd like to see something like that happen. Ask me again next year and we'll see if that's actually something that comes true. There might be more support services to come. I personally would love to see that. Peer support might become more of a thing. And then, maybe hiring of new personnel. I mean, once that economic need is there, I'm sure that the market will drive more and more people into the workforce. Other positive potential changes we're looking at reassessment of appropriate provision, delivery, data protection policies. Like, yeah, that's all true. Most of the regulations surrounding telemedicine are irrational at best. I think that it's different in every state. And how does that make sense? And there is a possibility that certain regulations and the way we look at doing these things might finally kind of get straightened out of necessity. And insurance coverage when it comes to telemedicine stuff might become a little bit more rational. The way we deal with controlled substances might become a little bit more rational. I think that's possible. But then again, if we get driven to loosen up too much, then 5 years down the road, we could be looking at some kind of other controlled substance crisis. So we'll see. Group outpatient treatments with online formats. Yeah, I don't know. Ask me again next year. Whether or not that's going to be something that's actually good, I think is hard to say. Less risk-averse approaches to monitoring of side effects. A little bit of a better appetite for risk might be a decent thing when we just don't have the luxury of bringing people into the office on an extremely regular basis. But then again, there could be negative consequences of that too. Less crowding on inpatient units. That is a highly ironic thing to say. It's like less crowding because people who should have been admitted aren't getting admitted. Like that might be what that means. Because right now, what I don't see happening is more inpatient beds in the country. So that would suggest to me that less crowding just means people are not in the hospital when they probably should be. And reassessment of necessary length of inpatient stays, again, I think that could go either way, and so could the whole conversation about compulsory treatment. So where do we go from here? Right, when we look at monitoring for COVID-19 mental health issues, well, number one, looking at the following indicators, it's like the proportion of all mental health services provided when you look at inpatient, emergency, institutional, outpatient, community, home-based settings. Like, yeah, sure, we've needed to take a big, long look at that for a long time. So that no better time but the present, since once again, I think quite a few holes have been revealed in the way that we do things. And those holes were always there, but it's no longer possible, to ignore some of it now. The rates of face-to-face video and telephone contact, it'll be interesting to look at sort of how that settles out, how much people are actually doing video versus face-to-face, and how motivated people are to do in person, and so on. Rates of prescription and use of psychiatric medication, that'd be an interesting thing to follow. And then, access to and use of the different services by people with pre-existing, but also with new cases of mental illness, and the characteristics of these users, kind of going back to the disparities in the way that different communities in the country were being kind of disparately affected by COVID-19 and are also disparately affected by mental health problems. Quality of care of different mental health services, that's going to be a big thing to look at, again, because we kind of can't get away with quite a bit of the stuff that we always did to try to hold it all together. Yes, a much, much harder look at what we're getting out of the interventions that we do, with a lot of risk assessment as to what we're putting into it in the first place, is probably very useful. And government and non-governmental financial support for mental health and social care services. Yes, I agree. I mean, who wouldn't agree that more support should be there for that? Particularly that, no matter what a big fan of the free market, anybody, including me, can be, many of our patients are not the kind of people that are really in a position to be spending money, on their own mental health care. And this is probably one of the areas where there's going to need to be a lot of social support if we're going to do right and we're going to do it well. So I would agree that needs to be watched, over the coming years. So in summary, the COVID-19 global pandemic has resulted in catastrophic, long-lasting mental health consequences. The combination of social isolation, lifestyle changes, economic destruction, and job loss did result in what looks like increased substance use disorders, family violence, depression, anxiety disorders, and suicide. Those with pre-existing mental health conditions and or underlying physical conditions. And I would argue those things go together like cookies and milk. All right, so and or is almost like saying and. I don't think you see very many people with significant pre-existing mental health conditions who also don't have a list of underlying physical conditions. And that group of people is particularly at risk for COVID-19 infection, severe course with COVID-19, and particularly at high risk for then exacerbation of the psychiatric condition. Healthcare workers like us, especially those on the front lines working directly with patients affected by the virus, are at high risk for mental health consequences. So that's welcome to the world of combat, because particularly in the very early days of the pandemic, yes, I agree. That's what it was like. It was a mass casualty situation. It's overwhelming. You don't know when it's going to be over. You're forced to make choices that are repugnant to you and are kind of forced to feel helpless. And particularly, it's bad enough if you've been trained for that. Particularly people who weren't really trained for that and didn't sign up for that, I can completely see how that's potentially going to lead to consequences down the road. Because of the pandemic, dramatic changes have been implemented in the approach to mental health care treatment, for better or for worse. But I think there are some opportunities that, if we jump on it, we can see things kind of getting better in the very near future. And it is essential that mental health care providers continue to monitor the effects of these changes and prepare for long-term incorporation. So long-term incorporation, meaning I think we're going to see mental health consequences manifesting for years to come that are going to be attributed to everything that we've just been through. But in addition to that, incorporation of some mandatory new ways of doing things. And if we do it right, might actually be better ways of doing things.
This episode has been brought to you by the NEI Podcast. With nearly 100 episodes, you can find us on iTunes, iHeartRadio, Libsyn, and virtually any platform that you prefer to listen to podcasts. If you've enjoyed this episode, we ask that you kindly leave a review for us. Go to any of the platforms mentioned and leave a star rating or a comment. We'd love to hear from you.